So hi guys, we are in the masterclass of post-burns neck reconstruction, post-burns neck contracture release, and we are discussing the intraoperative considerations in this particular video. So in the previous video, we have already discussed the preoperative considerations. Now we will be discussing the intraoperative considerations. There would be probably some questions which would overlap, but we will try to take an intraoperative perspective on those points. One of the commonest questions asked in exams is, can you release a PBC neck along with a PBC axilla? So the answer is it depends. There are no specific rules. It needs to be individualized from patient to patient. So if the only reason why we can't operate a neck along with an axilla is difficulty in splintage, because after a PBC axilla release we need to give a position of abduction possibly around 100 to 110 degrees. In abduction, a splint needs to be given for a prolonged period of time, and simultaneously when we release a neck contracture we also need to give a neck collar to the patient for a prolonged period of time. So that both is not going to be possible. It is going to be very difficult for the patient. It is going to be very cumbersome for the patient. So that is the reason why we don't operate a neck and axilla together. But if the neck contracture is of a type wherein we are going to need only a simple Z-plasty or multiple Z-plasties, there is going to be no skin graft over the area after we are releasing the neck contracture, then obviously there are no contraindications to operate a neck and a PVC axilla together. So if we are using a graft, it is definitely going to be tricky. It is recommended that we do it one at a time. But if we are using flaps, we can also do neck contracture as well as axilla contracture at the same time. So this part of the question we have partially discussed in the preoperative considerations. We have taken the patient on table and we are debating on whether to do an incisional release or an excisional release. If we have adequate number of donor sites available, our excisional release and grafting is going to give us good aesthetic outcomes. If we have unstable scars, if we have depigmented areas, it is better that we excise those areas. We can go for incisional release of the other areas, or the incisional release of the neck, but part of those areas which are depigmented, which are immature, which are unstable, it is better that we excise those areas. What to do in immature scars? In immature scars, if they are causing functional limitations, if they are causing functional problems, it is better to go ahead and release it and put in a FTSG or put in a flap, because when we are using a flap, the chances of recontracture even in immature scars are negligible or not there. But immature scar is there and there is no functional problem, we would suggest the patient to go ahead with massage, to go ahead with physiotherapy, to go ahead with neck mobilization exercises. And since the scar being immature, it is likely that it is going to improve with time as well. And then we wait for the scar to mature, and then we can go ahead and tackle that scar which is probably reduced to some extent because of our intervention. These points also we have discussed, but just for the sake of completeness of the intraoperative discussion, we'll just see one important point of each of the factor. Aesthetic outcomes are better with a skin graft as compared to a flap. Functional outcomes, recurrence rates are less in a flaps as compared to a graft. So that by that we mean that functional outcomes are also better because there are no recurrences. Specific indications of flap we have discussed: pediatric age group, mentally retarded patients, patients with hand burns. In short, all those patients who are not able to take care of their neck contractures by use of splints in the post-operative period, those are candidates for flap because there is going to be no recontracture. One more important advantage of flap over graft is flaps tend to grow with age. So in a pediatric patient, if we are going to do a skin graft, it is not going to grow with age. So eventually, even if the patient is going to wear splints, there is some amount of recontracture because of differential growth of the grafted skin versus